Thank you for joining us today, and allow me to introduce Dr. Vincent Ricchiuti. Dr. Ricchiuti obtained his PhD from the Department of Immunology and Molecular Biology at Université Louis Pasteur in Strasbourg, France, and Sanofi Diagnostic Pasteur in Paris, France. He trained as a clinical chemist in laboratory medicine at the University of Minnesota, Minneapolis, and is board certified by the American Board of Bioanalysis. Dr. Ricchiuti was the laboratory director of special chemistry, immunoassays, endocrine, and clinical research laboratories at Brigham and Women's Harvard Medical School in Boston, Massachusetts. He also served as director of clinical and special chemistry, immunology, and toxicology at the University of Cincinnati Medical Center, now UC Health, and associate professor at the University of Cincinnati, Department of Pathology and Laboratory Medicine at the College of Medicine in Cincinnati, Ohio. Dr. Ricchiuti joined Labcorp in Dublin, Ohio in 2015 as the laboratory director and discipline director in immunology. He is currently clinical associate professor at Ohio University, Department of Laboratory Medicine in Athens, Ohio. Dr. Ricchiuti is actively involved in several professional associations: American Association of Clinical Chemistry, American Association of Bioanalysts, Association of Medical Laboratory Immunologists, and American College of Rheumatology. Welcome, Dr. Ricchiuti.
Thank you, Nashwa. Today, and thank you all for joining the presentation. And I hope you can hear me loud and clear today. So we're going to talk about the clinical relevance of the D-denfine speckle pattern and the antibody associated, which are called anti-DFS70 autoantibodies. And first, we're going to look at the outline of the presentation. One question you need to ask yourself is, what is ANA? And we're going to also answer the question, why are we using indirect immunofluorescence assay called IFA? And then we're going to dive in the denfine speckle pattern and the associated antibody anti-DFS70. And then we will talk about profiles for diagnosis and triage of our patient. So, but first, what is ANA? And I hope you answer the question in your head. And what we call ANA is anti-nuclear antibodies. And more accurately, we call anti-cell staining because we look at all the antibodies directed against nuclear and cytoplasmic antigens. So we look at the whole cell. And the hallmark of autoimmune rheumatoid disease is actually ANA by indirect immunofluorescence assay, IFA, on EP2 cells. And we're going to go a little bit deeper in there. Also, at the same time, keep in mind that ANA positivity is not specific. What I mean is that positive ANA does not necessarily indicate autoimmune disease, nor the likelihood of developing one. It is true that positive ANA may occur in 13 to 25% of the healthy individuals. And those individuals do not have a systemic autoimmune rheumatoid disease, SARD, who are unlikely to develop systemic autoimmune rheumatoid disease even as 4 years as a follow-up. So this is how anti-nuclear antibody IFA looks like. The negative patient, called negative here, appear completely dark, but it will often display low level of non-specific fluorescence. If you look in the background of the picture, you can see some green, but it's very, very weak, as shown on the left side of the negative patient. The positive patient will display a bright apple green fluorescence, as shown with the positive homogeneous pattern. And as you can see with the arrows, the blue arrows here, we have the nuclear staining and the mitotic staining showing a very bright green color. And I also indicated the cytoplasmic area, which is totally clear for homogeneous pattern. There are representative here images of selected major HEP2 cells pattern. So with the nuclear location with homogeneous then find speckled, centromere, homogeneous nuclear layer for the most common one, and then the cytoplasmic pattern on the bottom here, which also are key for myositis, dermatomyositis, or even primary biliary cirrhosis. In the past, the Ep2 cells assay requested and ordered exclusively by rheumatologists, and that's what I indicate on the left side with the 60s here, as aid in the diagnosis of lupus and related disease. Over the years, however, the ANA test attained increasing popularity, and today, which is indicated on the right box here, the test is ordered by many clinicians from a variety of disciplines. These include general practitioners, hematologists, oncologists, cardiologists, gynecologists, neurologists, and gastroenterologists. Naturally, this implies a diminished pre-test probability of ANA-associated rheumatoid disease. However, given the reduced pre-test probability, one must expect a greater diminished post-test probability for ANA-associated rheumatoid disease, and thus the higher frequency for false positive in today's box. ANA by FA is the gold standard. More than a decade ago, the American College of Rheumatology created a task force to provide recommendations about ANA testing performance, standardization, and transparency. In 2010, the ACR published the recommendation as followed, and it's located in box 1 on the slide. Immunofluorescence ANA test should remain the gold standard for ANA testing. They also recommend that hospital and commercial lab use bead-based multiplex platform or other solid assays such as ELISA must provide data to ordering physician on request that their assay has the same or improved sensitivity and specificity as the IFA. And a more complicated request was the in-house assay for detecting ANA as well as anti-DNA and other ENAs such as anti-Smith, RNA, Rho, La, etc. be standardized using CDC or WHO standards. Laboratories should specify the method used for detecting ANA when reporting their results. So at Labcorp, if you go on the directory of services we have available online at labcorp.com, you can see that ANA can be labeled as IFA, immunofluorescence, or multiplex, or ELISA. So we indicate the methodology. During the 12th International Workshop on Autoantibodies and Autoimmunity held in Sao Paulo, Brazil in 2014, a full-day session was devoted to establishing a consensus on the nomenclature and staining pattern observed in ANA immunofluorescence test on Ep2 cells. The consensus nomenclature and representative pattern are made available online on the ICAP website at www.anapatterns.org. If you are interested to learn more. The patterns are characterized in the major groups as nuclear, cytoplasmic, and mitotic. And each pattern has been described in detail. And there is 2 levels of competency. The amber level, as you can see on the slide, is the competent level that each laboratory should achieve. However, there is also a second level, which is called the expert level, which is a higher level of expertise in green on the slide here. And Labcorp use both levels of competency. I want to indicate that the pattern are named from AC0 for negative to AC29 to topo I, and the dense speckle is now listed at AC2. And it has also indicated a metaphase plate is stained, which we will see in a minute. So the immunofluorescence assay, according to ACR and ICAP recommendation, is the gold standard testing. we really recommend to have patients screen with IFA as a screening, at least at the first technique. The IFA technique is preferred as a screening tool for detecting ANA, and the positive ANA should be titered if possible, and further investigation can be done with antigen-specific assays by ELISA, multiplexing, or other methodology. So as we said, the titer is important because you will get a pattern, so homogeneous, and a titer of 1 to 80 if it's a really weak positive, or a very high titer greater than 1280 if your patient has a lot of antibodies produced. And this is a table that summarizes the ANA antibodies. And I wanted to show you that table because we still call ANA the test individual antibody panel, because they are a mix of what we call ENA, which is the extractable nuclear antigen, which you will see sometimes, and the non-extractable nuclear antigen antibodies. And those ANA antibodies are listed here, and in purple, I mark the ENAs versus the non-ENAs. But as you can see, with these antibodies, we can classify patients in some disease. For example, systemic lupus erythematosus will have SNP and double-strand DNA, most likely positive. Patient with mixed connective tissue disease will have RNP, most likely elevated. Patient with Sjogren syndrome will have on board SSA and SSB autoantibodies. Scleroderma, mainly scleroderma 70. And for the polymyositis and dermatomyositis, you will have JO1 and other new biomarkers. So let's talk about the clinical relevance of the anti-dense fine speckled 70 and the antibody associated. And first, I want to tell you the story about the milestones in the discovery of the DFS70 and the clinical usefulness of that marker. So as you can see, the DFS70 was discovered in the 90s in serum recognized by DFS dense fine speckle by IFA in a patient with interstitial cystitis. And then later it was sequenced, and it was discovered as the same sequence or identical sequence as two other proteins. One is the transcription co-activator P75, and the second protein is called LEGGF. And then later on, in the early 2000s, we discovered that DFS70 is a key cellular cofactor for HIV integration. And also, initial observation that antibody against DFS70 are present in apparently healthy individuals. In 2010-11 or 12-11, there was described antibodies as potential exclusion biomarker for systemic autoimmune rheumatoid disease, and then development of algorithm, including anti-DFS70 antibody, and the development of the first commercial available diagnostic test for the anti-DFS70 antibody by Innova Diagnostics, now known as Werfen. And Labcorp performed the Werfen test or Innova test at this time. So when DFS70 were discovered, it was published their pattern as very bright speckle in the interface of the cells, as you can see in the box AB box here, and also the metaphase was clearly defined as condensed chromosome staining. The protein was located using patient anti-DFS70, that it was a 75 kilodalton protein. So you may ask, why do we call it DFS70? It's because the estimated molecular weight of DFS protein is actually 70 kilodalton. However, on the gel, it migrates at 75 kilodalton. We talked about the ICAP earlier, and the ICAP has a very clear description of the dense fine speckled. it's said that the speckled pattern distribute throughout the interface nucleus, as you can see with the blue arrows here, with characteristic heterogeneity in the size, brightness, and distribution of the speckle. Throughout the interface nucleus, there are some dense and looser area of speckle, and this is characteristic of the pattern, and we look for that when we look at those patterns. The metaphase plate in red arrow here depicts strong speckle pattern with some core speckles standing out. So when we look for the DFS70 pattern, which is very close to other pattern like homogeneous pattern, we make sure that we look at those particular characteristics. And I just wanted to show you the protein sequence quickly. As you can see, the sequence has been known now, and it's a 530 amino acids, and there is a N-terminal with a binding sequence which is called PWWP, which will bind to the chromatin of the cells and interact with the chromatin protein, and most likely has been involved in transcriptional autorepression and cancer. On the right side, there's another very important domain called IBD, which is the autoantibody region. So this is what patient autoantibody will recognize. And it also happens to be the HIV integrase binding domain as well, and the stress survival domain as well. So now, how do we explain why anti-DFS antibody exists? And it's shown in that little cartoon here. It starts with an environmental stressors that may induce increased oxidative stress and inflammation in certain tissues, led by drugs, allergen, irradiation like UVB, infectious agent, pro-oxidants, unhealthy diet, even smoking. And that leads to the stress response characterized by DFS70 upregulation and activation. So on one side here, on the left side, which I now number one, is kind of a moderate cell stress that we can have every day. And there is a cell survival response that involves DFS70. On the other side, it's a more severe cellular stress leading to cell death, a little bit like autoimmune disease and apoptosis and secondary necrosis under pro-inflammation microenvironment, and that will lead to some protein that will be cleaved differently, and both of these pathways will lead to loss of immune tolerance and production of circulating antibodies in genetically susceptible individuals. And I say that because we show that DFS70 has been associated with HLA, DR, DQ, and DP in some patients. And then I wanted to show you the potential role of anti-DFS70 antibody that you understand in red. Here you have the antibody, anti-DFS70, and they will have either a pathogenic effect by preventing DFS from entering stress normal cells and activate the survival pathway. So they will interfere with that. They will have a protective effect by preventing DFS from entering the stress cancer cell and activating oncogenic pathway. And then a protective effect by facilitating the clearance of the DFS70 cleavage fragments from the cell debris and avoid overproduction of autoantibodies. And then they also are involved in sensors of cell, which we talk about for stressful environment. So right now, we learned that DFS, or dense speckled nuclear pattern, is one of the most common IFA patterns encountered in ANA screening routine of clinical diagnostic lab, often occurring in high titer. We're talking titer of 320, 640, and greater. The autoantibody producing the DFS pattern target a protein of 70 kilodalton called DFS70, which is identical to two other proteins, lens epithelial-derived growth factor, LEGF, and transcriptor co-activator TCA-P75. In my talk, I will refer to DFS70. And DFS70 confers cell protection by regulating transcription of stress-related genes and is related to pathological of AIDS, cancer, autoimmunity, and inflammatory condition. So I mentioned the prevalence in a healthy population, and its exact prevalence depends on the screening dilution, because some laboratories will screen at 1 to 40, like Labcorp, and report to 1 to 80 or positive, but some laboratory may screen at 1 to 80 and report a 160 for a positive. It depends on the slide of conjugate use in the labs, and also vary from study to study. But this is a study published by Watanabe team in 2004 that showed that among routine patients that were tested, 20% of the patients will have a positive ANA. And that's very consistent what we see at Labcorp. And if we dive a little bit in those 20% positive ANA, what we see is that half of the ANA are over pattern, and half of the ANA is actually then-find speckle. So the then-find speckle can be up to 10% of the routine screening of patients for ANA by IFA. This is a study by Dr. Mahler in San Diego that showed that anti-DFS70 antibodies are more prevalent in healthy individuals compared to patients with systemic autoimmune rheumatoid disease. And they conclude that the prevalence in apparently healthy individuals was significantly higher than in all other diseases, including systemic lupus erythematosus. As you can see, the healthy population is close to 8.9%, when the other systemic autoimmune disease or organ-specific autoimmune disease are less than 6%. This is a table that summarizes the study from Ortiz and Hernandez that show that, and I indicated the disease listed on the left. I also indicated the total number of patients enrolled, just to give you an idea of the power of the study, and then the frequency with the mean and the range. So for ANA testing in a routine population, as you can see, antibody to DFS70 can be an average of 13%, which is consistent with the numbers we saw earlier. And the range can go from 0.8% to 37%, again, depending on the population and the technique. In healthy donors, it's around 8.9%, as we show, but the range goes from 0 to 21.6%. And then in the other autoimmune systemic disease, such as SLE, Sjogren, dermatomyositis, scleroderma, even rheumatoid arthritis, the percentage of antibody to DFS70 is much lower. Interstitial cystitis, which was discovered, is probably the highest in the study. Fibromyalgia is also 5.8%. What is very important here, I wanted to show you, is prostate cancer was 22.3% of patients had antibody against DFS70 versus the match control, which was only 5.4%. So DFS70 oncogenic marker. This study from Ortiz Hernandez, from a very recent study from 2020, showed that anti-DFS70 are not associated with systemic autoimmune rheumatoid disease and have a protective effect. They conclude that unlike other ANA, monospecific anti-DFS70 antibodies are not associated with systemic autoantibody rheumatoid disease and have been detected in healthy patients and some patients with non-systemic autoimmune rheumatoid disease inflammatory condition. They also conclude that these observations have led to the hypothesis that these antibodies could be considered as negative biomarker of systemic autoimmune rheumatoid disease and might even play a protective or beneficial role as well. Another study from Dr. Conrad showed that the findings of the study to date indicate that anti-DFS70 antibody also hold negative association with ANA-associated rheumatoid disease. And they proposed a testing algorithm for the routine diagnosis of ANA-associated rheumatoid disease. As you can see, the patient has screened with IFA screening on Hep2 cells. And if the patient are negative with the screening, they conclude that the association with ANA-associated rheumatoid disease is unlikely. If the patient is now positive, as you can see on the left side here of the slide, and then they look in the individual autoantibody in the cytoplasmic, in ANA over pattern, or even anti-DFS70 antibodies, they will conclude if the patient is unlikely, likely, or very likely. So if the patient has no autoantibody against other antibodies or DFS70, it will be unlikely. If the patients have negative other antibody, however positive with anti-DFS70 antibody, it's also unlikely. If the patient is positive for other autoantibody and DFS70, it's decreased to likely. So the likelihood is diminished. If the patient is only positive with other antibody and negative with the DFS70, in that case, the patient is very likely to have systemic autoimmune rheumatoid disease. Another study from Korea showed that isolated anti-DFS antibody without concomitant ANA-associated rheumatoid disease-associated antibodies may be an exclusive marker of those systemic autoimmune rheumatoid disease. And they conclude that the presence of anti-DFS70 antibody cannot exclude ANA-associated rheumatoid disease and should be analyzed in combination with other antibodies in the diagnostic algorithm. And this study was conducted to increase the importance of the diagnosis process of certain disease and association of the anti-DFS70 with systemic lupus erythematosus and systemic scleroderma. And what they conclude is that using the anti-DFS70 antibody associated with systemic disease can give a negative relationship between the antibody and this disease. And it could be a helpful tool as a marker for the exclusion of the ANA-associated rheumatoid disease when dealing with patients with non-specific symptoms attributable to this disease. So very helpful to kind of classify your patient into a non-systemic autoimmune rheumatoid disease. We just mentioned likelihood earlier, and this paper from a big study in Turkey showed that although the then-found speckled pattern cannot exclude the presence of systemic autoimmune rheumatoid disease, the likelihood is lower than with other patterns. And they concluded that anti-DFS antibody represent an important biomarker that can aid in the interpretation of positive ANA patients and therefore should be included in the test algorithm for ANA testing. This other study coming from Canada with Dr. Fritzler also elaborate about the likelihood ratio positivity for non-ANA-associated rheumatoid disease for anti-DFS70 antibody was higher. However, when considered in conjunction with other autoantibody, non-existing antibody, no coexisting antibody of the DFS70 pattern, and non-associated with ANA-associated rheumatoid disease, the likelihood went higher to 10.9. So this means that if your patient has DFS70 antibodies alone, the likelihood of not being associated with a systemic autoimmune rheumatoid disease is high at 5.4. However, if it's associated with other pattern, then it will be even higher. So relevance of anti-DFS70 antibody, the summary of what we discussed here, some studies have suggested that they are natural antibodies, protective antibodies that could serve as biomarker to exclude the systemic autoimmune rheumatoid diagnosis. We also discussed the anti-DFS70 antibodies, which are mainly IgGs, can be found at high titers in apparently healthy individuals and in patients with diverse non-systemic autoimmune rheumatoid disease inflammatory condition. When present in patients with systemic autoimmune rheumatoid disease, anti-DFS70 antibodies are usually accompanied by systemic autoimmune rheumatoid disease markers antibodies. Anti-DFS70 antibodies may serve as exclusion markers of systemic autoimmune rheumatoid disease when present as the only ANA specificity in the patient serum. Finally, anti-DFS70 autoantibody could serve as protective antibodies with no specific disease relevant, pathogenic antibodies in certain conditions, or sensors of increased stress and inflammatory cellular damage in the local microenvironment of the affected organ and tissues, as we discussed earlier. So we have at Labcorp profile for diagnosis and triage of your patient. The anti-ENA6 plus DFS70 profile is a panel that is used to include or exclude systemic autoimmune rheumatoid disease. This panel is provided with 6 clinically useful autoantibody to ENA, extractable nuclear antigen, and they are listed here: anti-SEM, anti-UN RNP, anti-RO, anti-LA, anti-scleroderma 70, and so on. And it contains also the novel anti-DFS70 by ELISA, as we discussed earlier. And this panel will help identify systemic lupus erythematosus, mixed connective tissue disease, Sjogren's syndrome, systemic sclerosis, and idiopathic inflammatory myopathy. And it contributes to the inclusion or exclusion of this ANA-associated autoimmune rheumatic disease. For example, if you have a patient that is positive with your ANA and on the ENA6 only positive for anti-DFS70, your patient is most likely not a systemic autoimmune rheumatoid disease. However, if your patient is only positive with one of those ENAs listed here, it's most likely associated with the systemic autoimmune rheumatoid disease. If both anti-DSF and one of those markers are present, it's also likely to be associated with systemic autoimmune rheumatoid disease, but not as the likelihood will be lower. So it really helped to identify those most likely to benefit from referral to a rheumatologist specialist, and may be useful to primary physician to better triage ANA-positive individuals and prevent unwarranted referrals to rheumatologists. So for the today presentation, we have a potential algorithm at Labcorp that we can use to help you classify your patient. We can screen by using IFA-EP2 cells, and if your patient is negative with the ANA, and we confirm that negative with any other antibodies, ANA-associated rheumatoid disease, and DFS70, therefore your patient is unlikely, as you can see on the bottom there in green, unlikely to be associated with systemic autoimmune rheumatoid disease and ANA-associated rheumatoid disease. However, if the screening is positive by ANA and the DFS70 are the only antibodies detected and the other antibody are negative, then it's also unlikely that your patient has systemic autoimmune rheumatoid disease. If your patient is positive with ANA and positive for both ANA-associated rheumatoid disease antibodies and DFS70 antibodies, as shown here, then your patient is likely to be associated with systemic autoimmune rheumatoid disease. And finally, if the ANA is positive and your patient is only positive with ANA-associated rheumatoid disease antibodies and the DFS70 is totally negative, then your patient will classify as very likely to be associated with systemic autoimmune rheumatoid disease. Let's look at an example. 47-year-old woman complains of fatigue and joint pain for the last 3 months. The joint pain involves the knees, hips, and shoulders. She denied any joint swelling and redness. The fatigue lasts through the day. She denied rash, oral or genital ulcer, chest pain, shortness of breath, or change in bowel or bladder habit. She feels that she can perform tasks, and she's not weak per se, but she's limited in the pain and fatigue. She saw a doctor 2 months ago who told her that her blood test showed she had lupus. She tends to be anxious and she's very worried about the diagnosis. Her past medical history has been unremarkable so far, and she's on no medication. Physical examination is remarkable for multiple periarticular tender points. The report of the ANA is not available to you, so you decide to repeat the ANA using Labcorp and to test by AFA on F2 cell substrate, which show actually a dense-fine speckle pattern at a high titer of 320. The anti-DFS70 antibody by ELISA was positive. The test for serum antibody to extractable nucleic antigens such as SSA, SSB, or urine RNP were all negative. And the rheumatoid factors and the rheumatoid specific markers were such as CCP 3.1, SA, SEP1, CARP were also negative, as well as 1433 eta was totally normal. So this patient is likely not to have systemic autoimmune disease, and her symptoms and physical examination may be more appropriately consistent with fibromyalgia. So let's go back to our table. Your patient was screened with F2 cell, was positive, and you find out that the DFS70 was the only autoantibody present. Therefore, your patient is unlikely to be associated with ANA-associated rheumatoid disease or systemic autoimmune rheumatoid disease. So let's summarize by those key message for you is that anti-DFS70 antibodies, a monospecific immunoassay that confirm the dense fine speckle pattern observed on ANA by AFA with F2 cells, is very useful, and it helps identify individuals who do not have an ANA-associated autoimmune rheumatoid disease, especially in the absence of significant clinical findings like we saw with that patient. Maybe it can be used also in ANA-associated rheumatoid disease-specific autoantibodies to include or exclude systemic autoimmune rheumatoid disease. We also talk about the likelihood ratio for the absence of autoimmune rheumatoid disease of 10.9 using the anti-DFS70 and may prevent unnecessary referrals to tertiary care specialists and unnecessary treatment. And as we discussed, it accounts for approximately 5 to 10% of positive ANA by IFA, even at high titer, which can be intimidating because the patient see a positive ANA and may be worried about that, and is rarely associated with active rheumatoid disease. Labcorp has published 2 technical reviews, one about anti-DFS70 as a standalone, and one about anti-ENA6 plus DFS70 profile. Those white papers are available to you and can be provided to you for review or reference. And I just wanted to share the reference I used today for this presentation. And I thank you all for your attention. Thank you.
Thank you for joining us today. If there's any questions, please feel free to put them in the chat and we'll be happy to answer them. Okay, so we have one question from Medical Affairs asking if we see rheumatologists using this test or more PCPs.
Sorry, Nashwa, can you repeat the question?
Yeah, do we expect to see more rheumatologists using this test or more PCPs?
That's a very good question. Actually, I would like to see the rheumatologists use more of the DFS70, both antibody and panel pattern, but also this test can really be helpful to primary care physicians as they take more and more responsibilities in screening patients for rheumatology disease, and can, it can help them to triage their patient and not send them for referral to a rheumatologist if it's not associated with systemic autoimmune rheumatoid disease. So I think it could be an amazing tool for a primary care physician as well. Thank you for the question.
All right, any other questions?
And Nashwa, I want to mention that DFS70 is 20 years old, so it's still a baby. So there's a tons of research going on as we speak to try to understand more and more of its role. So I'm sure in the next decade, we'll learn more about the usefulness of the DFS70. So we need to keep an eye as well on that marker, as it is, a new marker at this time.
Okay, it doesn't look like we have any more questions. So thank you very much, Dr. Ricchiuti. Thank you all for joining us today. And again, anyone who registered will be receiving a link to the recorded session. We hope you found today's discussion of value, and please keep an eye for the continuation of our series in 2023. Thank you again, and have a great remainder of your week.